Persistent pulmonary hypertension in the newborn, formerly known as persistent fetal circulation, and as the name implies, the transition from fetal circulation, where you have a patent ductus arteriosus and a foramen ovale that remains or that is open. At birth, those things do not properly close, and there's not the normal transition from fetal circulation to newborn circulation. And the reason being is that there is a significant asphyxia, hypoxemia, and persistent pulmonary hypertension that remains post-delivery. So with the first breath, where you should see the closure of that ductus arteriosus, it remains patent and leads to problems. It can be a primary disorder in and of itself, but typically it's seen as a secondary disorder, secondary to those things seen there. All those things that are there will lead to hypoxemia, and that's that hypoxemia that's the trigger for maintaining the ductus in its open position. What ends up happening then is you have a right to left shunt, and if I did not say this previously, let me say it now. You need to get a good handle on what I'm meaning when I'm talking about right to left and left to right. Come Monday, was it a song, I think, by the way. When we start talking about cardiac defects, some of them are right to left, some of them are left to right, some of them can be either way depending. Holy. But if right to left, though, you have venous blood being dumped into the arterial system. So this is a true shunt. This is a shunt for which oxygen therapy will not be of any benefit. Okay?
Say that again. Venous blood dumped into what?
Venous blood dumping from the right side of the heart, deoxygenated blood being dumped into the left side of the heart, or truly into the aorta if you want to be technical about it, through the ductus arteriosus, therefore leading to a true shunt. This is a shunt that that is refractory to oxygen therapy, and even positive pressure ain't going to help you. It's a big hole.
So it's just deoxygenated. An easier version is just deoxygenated blood going into the left side of the heart.
Correct. Through some opening between the two.
Right.
Yes.
So both the ductus arteriosus and the foramen ovale?
Not so much the foramen, because the pressure changes that occur, although because the pulmonary hypertension is there, the foramen can reopen again, but that usually isn't as much of a problem as the ductus. The ductus is the true culprit that is there.
So if you have a left to right, is it oxygenated blood going in?
You betcha, but that's not always a good thing too, as we'll talk about when we get to that point in time.
And oxygen therapy is
Refractory. This is a refractory hypoxemia. No matter what you do, you're still going to have that huge movement of blood from the right side to the left. Yep. Yes.
But it's not going to the left side of the heart,
It's going to the aorta, but basically it's going from the pulmonary. What should be going to the pulmonary circulation is instead being dumped directly into the systemic circulation. It's actually to the aorta. You are correct, yeah. But the way that I want to think of it is that you're going from the right to the left. Technically, yes, it's not through the heart. There are some defects where it definitely will be through the heart.
Exactly.
It's a right to left,
That's what's
right
germane.
to left shunt. Regardless of where the shunting is going through, it's a right to left shunt. And these kids, they're just born blue. So they look really lousy on an APGAR score. Typical signs and symptoms you would expect to see. If there's no pulmonary disease present, if this is the primary mechanism in and of itself, your breath sounds will be clear, your chest X-ray will be clear. And this is where we would do a pre and post ductal analysis and verify that I have good pre-ductal blood, but post-ductal blood, any area where you're monitoring that would be drastically reduced. Big significant difference. Couple different ways that you can look at this. I put them on 100% oxygen and see if my PaO2 improves. and unfortunately, it's not specific for PPHN. It's true for any of them, and same is true with the pre and post ductal PO2. Looking for more than a 20 torr difference between the two, that's indicative of some kind of a right to left shunt. Again, we don't know which it is at this case. Truly, what you need to look for is either a cardiac cath or a cardiac Doppler study using ultrasound to verify blood flow going through that ductus arteriosus, and that's probably the most sensitive mechanism by which we can determine. Cheap and easy, do a pre and post ductal. Again, doesn't confirm that that's the sole cause, but again, a lot of these things the PDA stays open for. The problem here is that I really got to get that oxygen level raised, because until that oxygen level raises, the prostaglandins will not be stimulated to be able to be, or released to be able to close that ductus off. So we want to maintain a decent PaO2, something high enough to begin the closure of that. Don't want it too high, because then you run the risk of retinopathy of prematurity. So it's a double-edged sword in the process. These kids often need to be mechanically ventilated, not so much for the PPHN as for the other problems. And because the process is so cyclical, often they require high frequency and ECMO as mechanisms to be able to control it. Keeping everything else normalized as much as possible, and the use of nitric oxide as a selective pulmonary vasodilator. Did we talk about nitric? I think we did, yes. Okay. And there's also the use of the drug sildenafil, which is a phosphodiesterase 5 inhibitor. Does anybody know what sildenafil is also known as? Viagra. That's correct. So, poor little kids, They're starting out on Viagra early in life. Then we'll continue on talking about intraventricular hemorrhage. Again, the degree of prematurity is going to dictate the degree to which the severity happens. Those lowest birth weights and the most premature are at the greatest risk. We diagnose it obviously by either a CT scan or ultrasound of the head. Unfortunately, children born of alcoholic mothers have a higher tendency to develop this. Like retinopathy of prematurity, there's 4 grades to this, and in this case, grade 4 is again the worst. Grade 1 would just be a small area of the ventricles of the brain. Grade 2 is where it's actually inside the ventricles. 3, the ventricles swell because of the blood. And 4 is where there's just bleeding all over throughout the brain. Do I expect you to know? Will I give you a scenario describing it? Which grade is it? No. But I want you to know that 4 is the worst, and obviously there's the greater the severity, the greater the impairment.
What is the alcohol related? How is alcohol related?
Don't know if that's just in the developmental process that the vasculature doesn't develop as quickly and is more prone to leakage. I don't honestly know the reason why that is, but it is.
Grade 4 survivability, probably not very good.
I don't know if I got that in there or not, but yeah, you're right. The higher the grade, in fact, grade 4 is about a 60% mortality, 50, 60%. So just as a review, the ventricles again are on the inside, where the lobes of the cerebrum surround it. There's another view as far as what they looked like, and a lot of things can cause this. Probably the biggest things that we're going to worry about are some of the disease states we have, and the degree to which you have stress placed upon the system. So severe hypoxia, acidosis, children who have thermoregulation issues, they're all going to be having a higher incidence of IVH. Yeah, hypermatremia. I'm not sure what the hell that is, but I think it has to do with a high level of motherhood or something. I don't know. That should be natremia, obviously.
It does say it.
Huh?
It does say hypernatremia.
They're just kind of merged together.
It's just close, but it's different.
Oh, okay. Yeah, you're right, it is. So here we end up seeing the grade 1, grade 2 into the ventricles, but no dilation, grade 3 with dilation, and grade 4 where it's actually seeped out of the ventricles and into the surrounding parenchymal tissue of the cerebrum. And it's kind of what it would look like on autopsy. You can just see the bleeding that is there.
Treated at this point.
So the 40% that survive would have a lot of damage.
Especially at grade 5, yeah. We're talking about profound cognitive dysfunction, motor dysfunction. It's one of those things where, yeah, the cure is almost worse than the disease, and it's not really a good way of wording it, but you get my idea. Prevent occurrence is the biggest thing, and just let me throw this out there, even though you don't have it in your notes. I know, normalized PCO2. Rick, you put that in at the last minute. Yeah, so what? I was reading Walsh earlier today, and I said, that's probably a good point to go over.
That blue book?
That blue book, yes. PCO2. I'll stop because you guys are writing. PCO2 has an effect on cerebral perfusion. If I hyperventilate somebody, drive the PCO2 down, I reduce the blood flow to the cerebrum. Okay? It actually is a vasoconstrictor of cerebral blood flow. If I allow PCO2 to rise, it increases perfusion pressure to the brain. Go ahead.
Is that why you get lightheaded?
Yeah. It's one of the reasons. Yeah. But letting these kids' PCO2 rise, permissive hypercapnia would not be a nice thing for these kids, because what you end up doing is driving more blood and basically worsening the bleed. The other end of that, well, why don't we just hyperventilate them? Well, the problem there is that you reduce cerebral blood flow. When you reduce cerebral blood flow, you also run the risk of having a cerebral infarct. Ooh, not a good idea either. So basically the bottom line is just try to keep it normal as much as possible. Try to prevent the event from ever occurring. That's really the true way of doing it.
Prenatal care.
Good prenatal care, good management post-birth as far as limiting the oxidative stress that the child is under. Yeah.
So we're saying that it's seen with increased incidence in alcoholic moms.
That's one small segment. Yeah, I mean, you'll see this in
Even without
absolutely. Yeah. Again, the more small they are, the more neurologically underdeveloped they are, the bigger risk they are, and they'll just bleed out, and then you got oh dear on your hands. I mean, just a huge problem, obviously, for mom and dad. Okay, that was exciting. Let's talk about something maybe a little bit nicer. Apnea prematurity. We define this as basically a breathing effort where a cessation of any effort is present for 20 seconds, which is different than in the adult, by the way. Or anytime you have apnea that's long enough to induce cyanosis, bradycardia, or both. And again, we're talking about kids that are premature. This is, again, different than periodic breathing. This is truly an apneic episode that's leading to bradycardia that's significant. Okay? And you'll see this again, the smaller, the younger the child, the more premature the child, the more often you'll end up seeing it. And again, neurologically, they're not fully developed until pretty much term, so any baby born preterm is going to have problems where the respiratory centers aren't functioning the same as they would be in a term baby. Treatment for it really is just monitoring them, keeping an eye on them. Positioning can help. Changing positions frequently help. Stimulation works wonderfully. There actually was, I don't know if they still do or not, but they used to take the IPB machines, attach the circuit to a rubber glove, a latex glove, put the glove underneath the mattress, and just that moving of the mattress was significant enough to reduce the incidences of apnea. I should ask Rita if they're still doing that or not, but it was a neat idea because you can put the timer on the IPB machine and it just goes ahead and keeps on cycling. Also, low-dose caffeine is utilized because caffeine is a respiratory stimulant, and that's what I was talking about. But the oscillating water beds or bump beds or something where you can do some stimulation there. Kind of cool. Choanal atresia, choanal atresia. This is a congenital malformation of the nasal passage where you end up having either complete or partial obstruction of airflow through the nose. If you remember, infants are obligate nose breathers. They primarily breathe through their nose. Close that off, you got some problems. Interestingly, their respiratory distress subsides when they cry because now they're able to get airflow in. They're trying to breathe in through their nose and there's either a partial or complete obstruction. Once they start crying, they're able to get air in and kind of they look a whole lot better. Kind of oddness. The way we diagnose it is kind of gross, but it works. You try and pass a nasal catheter through the nasal passage. If you can't pass a nasal catheter, or suction catheter, then you got an obstruction. And literally what they need to do is puncture that obstructive element here, create a surgical opening into the posterior nasopharynx through there. Pretty simple mechanism to be able to manage. What you'll see with these kids though is they end up having typical respiratory distress syndrome, tachypnea, retraction, cyanosis, but they'll also have a lot of nasal secretions, where ordinarily that's not a common finding. One thing that we will do or can do is put an oral airway in if they will leave it in, and as Mary's talking about that, isn't she? She will be next time, because you'll have not only the CPR but also the bag valve mask and the airway management process. But if it gets severe enough in these kids, then we will tube them and possibly ventilate them, or at least use some CPAP on them. Macroglossia. Now 4 years ago or 3 years ago, I never taught this, but then I started seeing people telling me, "Oh yeah, we saw this kid. You never told us about this." Oh, I guess I'd talk about it. This is basically macro-large glossia tongue. They have a mammoth tongue. Usually it's associated with other types of syndrome, like Down syndrome. Sometimes prone positioning, lying them on their belly, can help out because the tongue is so large it can actually become obstructive, and they can actually do surgical reduction of the tongue if necessary. And you'll see a lot of kids at camp that have macroglossia. And
What causes that? Do we know?
it's just a genetic defect. The tongue just grows bigger than the head. You will find that the good Lord, lots of mistakes along the way.
But you said it also goes along with Down syndrome.
Yeah, there's other genetic defects that can be there. On the other end of the spectrum, you can end up having what's called mandibular hypoplasia, meaning I have a small mandible, also known as micronathia. This is found, and the one that you'll want to keep in mind is something called Pierre-Robin syndrome, because that's the most common one that we end up seeing. There is another one, Treacher-Collins, but more commonly Pierre-Robin. And Pierre-Robin has 3 components to it. Micronathia, which is a small jaw. I'll show you a picture of a kid. Glossoptosis, which is basically a very small tongue, and the tongue is actually retracted back into the throat. And they often have a cleft palate, and they'll have a cleft palate as part of that syndrome also. And these kids basically are just an airway problem, because the tongue isn't fully functional. It can lead to obstruction even though it's small, and they have problems maintaining secretions in the process. So really, again, here, prone positioning, use of oral or nasal airways. Most often than not, they have to go for some kind of surgical repair. They may need a tracheostomy until they can be stabilized in the process. But here you can see some kids, you can see the jaw being just massively small. They're cute little kids, but very, very large airway problems associated with it. Okay. Micronadia. Esophageal atresia and tracheoesophageal fistula. This is basically a situation where either you have a connection, a communication between these two structures, that's a fistula, or an atresia is where one of the two of them, well, let me rephrase that. How about the esophagus? Well, I can actually have the trachea too. I shouldn't say that. But basically, they end up having a blind pouch. Okay. Now, in the case of the trachea, there has to be a fistula above, below where the pouch is. Otherwise, you wouldn't have a child was able to breathe. Okay. It's congenital abnormality, and quite often, usually with the first feeding, we end up finding, we got some problems here. The most common type is an upper atresia of the esophagus and a lower TEF in the process, but there's multiple options you end up having. Here I end up having a trachea and an esophagus. The esophagus has no connection in this case. So as you feed that child, they just aspirate. Here you have one where trachea is good, but again, you feed them and they aspirate. Here's one where you feed them and they aspirate, and they aspirate, and they aspirate. And you get the general gist, okay? Any combinations possible. The most common one is A, that you end up seeing where you have an atresia of the distal esophagus and a tracheoesophageal fistula below that.
It's like the blind pouch you're talking about.
That's the blind pouch on the esophagus. What they try to do is try to pass an NG tube, and they basically are able to verify via bronchoscopy, ultrasound, or any chest abdominal x-rays that the catheter is not moving and is kind of just stuck there. And the only reason to be stuck is to get an atresic esophagus. Again, a lot of pooling of oral and nasal secretions, a lot of drooling. The stress is usually associated with feedings. Otherwise, they can be pretty well normal beyond that. And they can have some aspiration leading to some atelectasis and pneumonia. And their gut doesn't drain normally because of getting a lot of air into it. So what you end up needing to do, obviously, is surgically correct it and just supporting it until that time can come. Putting the feeding tube into the esophageal atresic pouch can remove secretions from them, and this is a kid also that we would put in an upright position. And they often will have a G-tube in place, a tube which is basically a surgical incision into the stomach to feed them. What else can go wrong? Well, we can have a hernia in our diaphragm. That doesn't sound good. Hernia, again, being just where the muscle that should be connected together separates, and in the case of an abdominal hernia, you end up having the bowel moving out through the abdominal wall, and if not treated, that can obviously lead to compression and necrotic bowel in the process. This is one where you end up having the abdominal organs herniating up into the chest through the diaphragm. This is not a good thing. Couple different reasons. One, the lung tissue itself is compressed, and we'll find that the lung is what we call hypoplastic. It's underdeveloped. Because this happens all through uterine development, or intrauterine development, I should say, they end up having a lung that's hypoplastic. Second thing that happens is after birth, these are the kids that anytime you ventilate, all you're doing is worsening the problem because you're putting more air into the gut, if you will, and in the process worsening the problem. Usually it's the posterolateral region of the diaphragm and something called the foramen Bactolek. You probably want to remember that. It's most common on the left side, very rarely on the right, but it can be. On the left you end up having, and by the way, when it's on the right it's a whole lot worse too, because the liver is much less compressible than the bowel is. But you'll see the stomach, spleen, intestines, everything else entering up into the chest. Because those organs have shifted position, the abdomen actually appears what we call scaphoid or boat-shaped. Okay, so the large bowel is still there, so that portion of the abdomen is elevated. The abdomen just above or just at the proximal point of the diaphragm is elevated, but everything between is missing. So it looks like a boat. Concave, yeah. So here's a picture as far as what this looks like, and you can see that we're having the small intestine, stomach, spleen all move up into the chest, and that prevents, obviously, for one, it's going to shift the heart, shift the trachea and everything else, but it also compresses the lung. And here you can see the stomach and bowel. My trachea's over here, my heart's over here, everything's shifted over in the process. These kids look like crap from the very beginning. Point of maximal impulse is shifted, obviously, because the heart is shifted. Breath sounds may be absent over the left side, in fact, which you'll probably hear our bowel sounds instead. That's kind of a freaky thing. We can look in a chest x-ray and confirm it, and then we talked about those lungs being hypoplastic in the process. First thing we need to do is place an orogastric tube to try and decompress whatever air is in the esophagus and the stomach. We don't do manual ventilation until these children are intubated, which is the top one priority. Get them intubated. So we're ventilating what lung we do have available until we can surgically get them, get this corrected. These are kids that often need, for one, they develop PPHN secondary to the hypoxemia that exists because we only have one functional lung. Secondly, they more often than not require high frequency ventilation and ECMO. So you'll see them go to that rescue therapy right off the bat in these kids. Very high mortality. Because you're ventilating one lung, the chance of that one lung rupturing goes up. So they're a mess. Good news is you can actually diagnose this on ultrasound, and they have done repair in utero. Literally going in, opening up the amniotic sac, opening up the baby, doing microsurgery, closing everything back up, and then when time comes, they do a C-section and pull the baby out, and all is well. It's crazy, but the good news is you don't have the hypoplasia of the left lung in the process. Some other chest wall malformations. The two that you should be aware of are pectus excavatum, or funnel chest. It's the most common of them. Both of these really are a restrictive disease process, but more so the excavatum. Get some heart displacement, and they can do some surgical repair if it's significant enough. And pectus carinatum, or pigeon breast. Interesting, you see it later in life more than you do at birth. And it's basically just where through the growth process, the sternum becomes separated and actually starts moving outward. And there you can see the funnel chest on the left, and the excavatum on the, excavatum on the left, and the pigeon breast, the carinatum on the right. They just look funky, you know. Yes.
One of the
Really none.
It is treatable. Well, I don't know. My brother had it, and the doctor told me as he was getting older to lift weights, and that would.
Strengthen the musculature around her. That makes sense.
I had a buddy that played Division I football that had that,
Yeah.
that excavated,
Excavate them or the carinate them?
that excavated.
Wow, okay. Depending upon how significant the restriction is going to dictate what the limitations are. But not so much the carinatum, it just kind of, bones grow weird. All right, for this lung bud anomalies, Walsh goes through a pretty good explanation of them. And all I really want you to know is that during that initial phase, the 4th, 5th week, when the lung buds are starting to develop, something goes awry. And there's just weirdness that happens. I don't know how better to say it. The bronchogenic cysts are basically just small areas of truly a cyst that is self-encapsulated, that has alveoli and airway tissue, both types, there. It's not connected to anything, so it doesn't do anything. It just takes up space. Same is true with a congenital cystic adenoid malformation. Same idea. You end up having airways and tissue that aren't connected to anything, do have blood flow, but they can actually get large enough that they become almost like a tumor, literally, and have to be surgically removed as far as a lobectomy or something along that line. Pulmonary sequestration, as the name implies, means that it's an airway that has what would be functioning alveoli, but it's not attached to anything. It's just kind of an extra airway that you have there. Weird. And lobar emphysema, same thing. It's basically a part of the body where it's connected to the systemic circulation, not to the pulmonary circulation. So it has, even if it was functioning, it's not being attached to anything. Key thing is you can either see this when they're first born, or with some of them you find them later in life. Some of them require surgical repair. Some of them, if they're small enough, we just ignore. Okay.
So on the first two, there's a VLI and a cyst, but there's no airway going to it?
Correct. There's no connection to the airways. Yes.
First 3.
Really, all of them. Either there's air going there, or there's no blood flow. Either way, it's not a functional unit.
Like the sequestration, that's like a branch laying in there that's not.
It's not connected to anything. Weirdness, to say the least. They're rare, so you probably will, it's one of those things you might see once in your life if you work a lot of NICU. Just bringing it up for completeness sake. Lung buds. Very early in the developmental stage, something goes awry. And this is just kind of showing what they're talking about as far as that lung bud stage. So at this point, prior to the lobe fully developing, they end up shooting off on their own.
Signal didn't get passed.
Yeah, it's one of those. Pneumothorax can occur again in neonatal, can be just something that's spontaneous, can be obviously iatrogenically induced, can be something that occurs secondary to high ventilating pressures. And similar to what you guys learned when Jeannie talked about it, the only difference is that we can do something called transillumination on a neonate. Transillumination is where I take a fiber optic light source, put it up to the chest wall, and what you should see is just a small halo of light around the end of that at the end of that fiber optic light source. So it's basically just a small halo that's there. If you see something where you see that light diffracted out through, that means that lung below it is not inflated. Rather, there's air there, and the air is able to disperse itself throughout the chest. Obviously, then you can get a chest x-ray, determine the size of it, and manage it the same way that you would any pneumothorax. In the emergency situation, you can do a second intercostal space, needle aspiration, mid-clavicular line, followed by a chest tube, and then go ahead and manage them to prevent any process. Okay, these two. Gastroscosis, umphalocele. Gotta love them. This is again where there's a defect of the abdominal wall. Abdominal wall doesn't close. The abdominal contents are presented at birth outside of the abdomen. Usually it's at the level of the umbilicus. The difference between them is the umphalocele has a membrane that surrounds it where the gastroscosis does not. God, I hate saying that word. Want to make a guess which is which? Yeah, it's the one on the left. Umphalocele, you see there is still inside a membranous sac. So what they need to do, obviously, in both cases, but more severely in this one, is place some sort of covering over it to protect that tissue and transport and get them to surgery to have that surgically repaired. That's awful looking, isn't it? Makes you never want to eat sausage again. Yeah, that's a little bit better. Still in the package, but you can still see it. Okay, necrotizing enterocolitis. I think this might be the last one I have. I don't know. Is it? Yeah. Okay. Because you guys have had enough initials for one day. NEC is basically a situation where you end up having the bowel itself not having adequate oxygen being delivered to it, so the mucosal, due to low blood pressure, specifically hypoxia, or inappropriate feedings, and again that's more of the rare one than anything else, but basically that mucosa becomes damaged. It doesn't secrete its layer of mucus, and basically then the normal flora that is there cannot thrive, and other pathologic organisms begin to grow. Okay? In the process, you end up developing ischemia of the intestinal wall, eventually necrotic and gangrenous bowel is what's left.
What do you mean by inappropriate food?
Hyperosmolar is what we normally don't feed somebody, but if for some reason or other the feeding has a higher, is a very concentrated solution, they can lead into problem. We see this a lot with RDS because the kids are hypoxic and with low blood pressure, and lo and behold, the smallest kids are the biggest risk, as I probably have said about every disease thus far. This is why we try and keep them in as long as possible. What you end up seeing is dilation of the intestines. The intestines themselves are filled with gas, which causes the bowel to be inflamed. You end up with a lot of gastric ileus, where the fecal matter cannot proceed because the ischemic bowel loses its ability to contract in the normal peristalsis. What stool may come out as it's a bloody stool, and obviously these kids are just a nightmare to feed because the normal way you would feed them you can't do. You can't even put in a connection through the stomach because everything distal to that is damaged. And this is what it would look like on an abdominal film. It doesn't show up as well for you as it does for me, but these are just huge spots of black bowel. Just basically they're just necrotic. Here's what you end up seeing. This is an autopsy. You can end up seeing the nice healthy bowel on the left, and that's just dead bowel. That dead bowel promotes an infection. Septicemia develops. The kids just get massively septic and ultimately don't survive. Very, very bad. Treatment, stop feedings, trying to get feeding in other mechanisms. That's what hyperalimentation is. Hyperalimentation means that I'm going to place into the IV or place intravenously food, although it's obviously an IV solution that's high in protein, fat, and carbs. Because they're prone to infection and antibiotics. I have 20% require surgery. A good portion of the ones that don't require surgery is because they don't make it.